welcome to this symposium kindly set up for us by Terumo. So during the next 25-30 minutes, we're just going to look at the use of the latest drug-eluting stent, so the Ultimaster stent, through its various iterations in complex PCI, and of course focusing on bifurcations because we're all here because we're obsessed with them. So we've got some great cases brought to me by my co-chair, Dr. Aminian from Belgium, and that's going to illustrate the flexibility of the latest generation stents and the sort of cases that we'll be studying in Nagomi complex, which is the registry which has started already. Sorry, it's me doing the slides, isn't it? So first of all, we'll just look back at the development of the Terumo stent for complex lesions. So Discovery 123 looked at a small study, and this was just in 60 patients looking at strut coverage with OFDI at 1, 2, and 3 months, and proved that there was 95% strut coverage at 3 months, and by 1 month, 85% strut coverage. And there was some looking at the clinical outcomes, which were comparable to Xience, but only a small study. And then we went on to Century 2, which was a multi-center trial of Ultimaster, looking more at clinical endpoints, so target lesion failure at 9 months, which was about 4.5%, and comparable to Xience. And that was with 500 patients in each arm, so a much bigger study. And then most of us are familiar with Ultimaster, which was a huge registry. We enrolled about 37,000 patients, all comers, prospective registry, and that was looking at 1-year outcomes. And that was quite interesting to look at the number of complex patients that were included in that. And it comes out at about 20%, so about 10,000 came into the category of complex there. And then MasterDapt was more looking at complex patients rather than complex lesions, so those who needed dual antiplatelet therapy needed anticoagulation alongside their antiplatelet therapy, and whether we could reduce the duration of that. So Century 2 included a bifurcation sub-analysis. There were just 95 in each group, and gave the idea that although there's not enough numbers really to show much statistical significance, that it was comparable to the Xience drug-eluting stent there. And then in Ultimaster, there were 4,400 bifurcations in Ultimaster, which really gave us a big body of evidence to look at what was going on in a large registry of bifurcations with drug-eluting stents. And some sub-analysis were done of those. One of them showed that the endpoints were adverse in the group that had significant disease in the side branch, so the 111 and the 011 or 001. So anyone who had significant disease in the side branch had a worse outcome than those who didn't. And we were able to look a bit at technique. So as in most big registries, 2 stent bifurcations, if you start off with letting people do what they want, and people who work provisionally a lot of the time, 2 stents were used ultimately in about 23% of patients. And actually, if you look then retrospectively at these patients and say if people were allowed to do 1 stent or 2 stents as they found appropriate, and about a quarter of them got 2 stents, the outcomes in the 1 stent and 2 stent are very similar, with perhaps just a slight signal for stent thrombosis. And that's an interesting comparison to the kind of randomized 2 stents versus 1 stent study, I think. The other analysis was looking at POT, and probably the word hadn't got out then in that study about the importance of POT. People knew what it was, but perhaps we hadn't preached about it quite so much. And in 66% of patients, there was no proximal optimization, and they had worse outcomes. So that was kind of retrospective proof of what this club have been saying for quite some time. Kissing was also undertaken in a similar proportion, so about a third, but the signal wasn't so big if you kissed or didn't kiss in terms of outcome. And then there was an analysis of male versus female, and surprisingly, there was no difference. So onto the new generation of the Nagomi stent. So that's, for those of you who are using this now, it's got 3 platforms now rather than 2. It's got a huge number of sizes available. You haven't really got room on your shelf in the cath lab for everything that's available there, but importantly, you've got lengths up to 50 millimeters, so 44 and 50 millimeter lengths, and 2 millimeter, 4.5 millimeter diameter stents. and optimized overexpansion capacity. So anything above a 3.5 will go up to 6.25 by the instructions for use. The stent's got a new hydrophilic coating, so it's supposed to be more deliverable than the previous iterations of the Ultimaster, but otherwise it's built upon the evidence and experience of the Ultimaster family. So without further delay, I think we'll move on to some Nagomi cases and talk about some of the patients that are going to be in the Nagomi complex study. So that's going to be 3,000 patients, a complex PCI, and what comes into complex you can see here. So, sorry, on the next slide. So long lesions, left main, calcification, multivessel, bifurcation, and there's going to be QCA analysis of the bifurcation group intentionally, CTOs and restenosis with clinical follow-up. So 3,000 patients. We started April this year. It should finish by September next year. And I think some of the cases you're going to present are already in that registry.
Thank you very much, and thank you for the organization to inviting me to present those cases. So don't hesitate to interrupt me at any time during my presentation if you want to comment on any cases that you would like. So the first case, it's of course, all cases were done with Nagomi, but it's a 55-year-old male with dyslipidemia, or untreated at the time of presentation, presented with acute coronary syndrome and non-ST elevation MI. The ejection fraction was 55% with hypokinesia and the anterolateral wall. The patient could be considered as a low bleeding risk because the precise DAP score was less than 25 and the renal function is totally normal. So I'll show you the angio. So we can see a very long lesion going from the proximal circ to the distal circ with some spot of very tight stenosis. So we see that the ostium of the marginal branch actually is not really diseased. And there's another lesion on the mid-LED, a very tight lesion also. So we decided to treat both lesions ad hoc because it was an acute patient. So here, if you look at the strategy here, so we could say that it's circumflex non-true bifurcation with a Medina 110. So there was two options. One is to put a stent proximal in the proximal circ and one in the distal circ, but we felt that probably we'll ended up in the proximal part in somewhere in the plaque, and we decided to go really cross the marginal and to really do like a bifurcation. It was a long lesion, so we decided to go for a provisional stenting strategy with a point side pot. And this is an acute setting, and we are quite late in the afternoon, and it was difficult to go for intravascular imaging, so we went only for angio guidance. This is real life, actually. Anyway, the patient was fulfilling the criteria for the registry because he had 2 vessel disease that we are going to treat, so this was one of the inclusion criteria. So we see that very simply, so we predilated the distal circ and the proximal circ with a non-compliant balloon 2.75. And then you see the crossing of the new size that we have now, the 2.75 50 millimeter Nagomi stent, which was actually covering the full lesion from the proximal circ to the distal circ, actually, which was inflated at 14 atmosphere. Then, of course, the pot with a 3.5 millimeter semi-compliant balloon. We always use, we try to use in most of our cases a semi-compliant balloon because we think that the apposition will be better as compared to a non-compliant balloon. And of course, when you stent such a long length of lesion, you must ensure that the pot really covers the full length of the stent in its proximal part. So we went really. We ensured that it was the case, actually. Then side branch opening with the 2.75 non-compliant balloon, and the final pot with the same balloon, actually. And this shows you that we use the stent enhancement to be sure that actually we are really doing the pot because that, of course, it's a reason I will show that in the next case for abdominal passage of a wire if you don't pot really the full length of the stent in the proximal part. So still we're not happy with the distal part, so we did another post-dilatation, and this is the final angiographic result. So this is without intravascular imaging control, but we think that the angiographic result was quite acceptable in this case. So this is the first case. And then, of course, the LED was treated straightforward with a pre-dilatation and a 2.75 and 21 millimeter Nagomi stent. This is the final result. So the second case I will show you is more Yeah, why we use the pod side pod, this is open to discussion, but I had the opportunity to be part of this OCT trial that was actually published in Neurointervention 4 years ago. And this is one of few trials or studies really assessing live intravascular, the one technique actually, pod side pod, and this was done with OCT. So there was a run before, after placing the main stent, and after doing the full report sequence. And what this study shows is that actually it brings very good result in terms of proximal apposition, distal apposition, and also in terms of side branch obstruction, which is actually very low. And most of the time you don't have to go for a kissing. And that's why it's our preferred technique when you have to do a provisional. We do always a pod side pod, and we do a kissing balloon inflation in only a few cases. And that's really my way of working. And this is further assessed in a large multi-center registry, which has now completed and is submitted actually to a journal under review with, and I can tell you, very good results in terms of target lesion failure. And the second case, so it's an 82-year-old male with a permanent atrial fibrillation. The patient is on NOAC, rivaroxaban, 15 milligram. He has a known ischemic heart disease with previous DS on the mid LAD and also the distal LAD. He has a previous pacemaker, there's a former smoker, so the presentation is again an acute coronary syndrome, non-ST elevation MI. Ejection fraction is 50%, and the patient has on the transthoracic echocardiogram and hypokinesia on the anteroapical segment. The renal function is normal, however, the patient had several previous serious GI bleeding due to diverticulosis and angiodysplasia. So this is the angiogram of the patient. You see there is a tight lesion on the intermediate branch that you can see on the top of the screen, but also the very complex lesion proximal to the previous implanted stent at the level of the proximal LAD, involving a very large diagonal, which is diseased from the ostium and more than 10 millimeter beyond the ostium, I would say. So who would go here, for example, for a two-stent technique in the room? I think, okay, I have the light just in my...
Probably a minority for two stents.
A minority will go for two stents. Interesting.
Who's going for no stents?
Okay, interesting. And maybe at DCB, why not? I mean, yeah. We have had very...
people going for no stents.
Interesting discussion.
And who would go for just a provisional and ignore the diagonal?
Okay.
Okay.
So here was our strategy. So it's a LED diagonal true bifurcation. So it's a Medina 011 because the proximal is not really involved. The lesion length at the level of the side branch is clearly more than 10 millimeter. This is a very important side branch. So we decided to go for a planned two-stent strategy using one of the preferred technique from David Ildick-Smith, which is the DK crush. He loves that, I know. Every meeting he presents, no, it's a joke. So here we decided to go for a nano crush because we wanted to decrease, because of the angle of the diagonal, we wanted to decrease as much as possible the overlap of struts in the proximal segment. So we went for this technique, actually the nano crush technique, with a minimal overlap of, let's say, 1 millimeter, not more. And just I would show you that I recently had the opportunity to do some bench tests with the Nagomi stent. You know, when we do the bench test and you do that kind of two-stent techniques, sometimes you see very impressive deformation of the stent that you could probably not see live on angio, actually, unless you do intravascular imaging. And even then, you have to do reconstruction and so on. So it's interesting to test this stent in bench test, especially when you do the two-stent technique. So I'll show you here, I had the opportunity to do that nano crush technique. So this is a bench model with a 2.75 diagonal, 3 millimeter distal LAD, and proximal 3.5 at the level of the main vessel. So this is first in the diagonal, I would say diagonal here, a 2.75, 50 millimeter Nagomi stent. And this is the crush with there's always a discussion about what size of balloon you should use, but here we decided to go in between the proximal and the distal, but usually it should be close to the proximal main vessel. So it's a 3 millimeter diameter semi-compliant balloon that we inflated for crushing the stent in the diagonal. Then this is the result after the first crush, and then the stent is implanted directly. So the nano crush, you skip actually the first kissing balloon inflation and you go directly with the main stent. So this is a Nagomi 3.21 millimeter stent. This is of course a pot, which is very important, with a 3.5 millimeter semi-compliant balloon placed at the right spot. Then the rewiring through a proximal strut, very important, and the kissing balloon with 2 non-compliant balloons. And the final pot, which can be, of course, more proximal because the kissing balloon has already done the job at the level of the carina. And you see here the final result. And you see very nicely that actually the architecture of the stent remains relatively good, despite all these maneuvers when doing this bench test. So we try to replicate that in live here. So we see first predilatation of the LED, then the diagonal, not diagonal first, sorry, and the LED. And then a very long stent, again 50 millimeter Nagomi 2.75 was placed in the diagonal using the nano crush technique because we wanted to cover as much plaque as possible. I know that the advocate of DCB will not be happy with that, but okay, that was our strategy here. Of course, the balloon was already placed in the proximal LED for crushing the stent. So this is the placement of the stent and then the crush. And then we placed the other stent in the LED. It was a 3 millimeter diameter and 38 millimeter length Nagomi stent in the proximal LED, and we had to be sure that we were not protruding into the left main, so we had to do a different views. Of course, the pot, very important, the pot with the 3.5 millimeter semi-compliant balloon. And this is the stent enhancement of the crush. And then rewiring, of course, we didn't do the first kissing, so of course the rewiring of the diagonal was not an easy one, but I can show you here that after several attempts it worked. This is, I think, a cyan blue express report wire. This is our regular one. And then, of course, the kissing balloon inflation. And the final pot, of course, again, more proximal. And this is the final angiographic result. So there's a good discussion in this case about what will be the antithrombotic strategy in this case. We cannot move forward. This is the stent enhancement of this case. Again, it was an acute setting, and we didn't go for intravascular imaging, but I will show other cases when we did it. And okay, in this case, we can also, like Helen said, build on previous knowledge that we have with, I would say, with the Ultimaster Tansei technology that was assessed before in the master DAP trial. And we know this trial, patients at high bleeding risk were randomized 1-to-1 to receive an abbreviated antithrombotic strategy as compared to a regular one. And if we look, and patients were also stratified according to the fact that they were on oral anticoagulant therapy or not. And if the patient were on oral anticoagulant therapy, and were randomized to the abbreviated therapy, it was after 1 month of DAPT, it was single antiplatelet therapy for only 5 months as compared to 3 months of DAPT in the other group. And what we see in this trial is that this is the two curves, when you look at the right graph, this is the two curves at the top, that the patient that were on abbreviated antiplatelet therapy, I mean only 1 month of DAPT and then only SAPT in patients that were taking oral anticoagulant drug had less bleeding without increasing the ischemic risk. So we can build on this to say that in this patient, the precise DAP score was very high, actually 71, because all the previous GI bleeding, the OAC, the age of the patient, and so on. And so if we look at the recommendation and the guidelines, we can estimate that this patient has an acute coronary syndrome, but we can estimate here that probably that the bleeding risk is outweighed actually the ischemic risk. So we decided to go for this strategy, 1 week of triple therapy, and then only clopidogrel for 6 months with the rivaroxaban low dose. So the third case, it's a 77-year-old male with dyslipidemia, hypertension, a previous also drug-eluting stent in the mid-LED and also proximal LED using, again, pod side pod, and you will see the result after several years. The patient has angina, he has a good ejection fraction. He has a positive stress test on the anterior wall, actually. And the coronary, control coronary angiography shows a significant distal left main lesion. The renal function is normal, the patient is at low bleeding risk. And this is the left main. So this is not the most complex left main that we have seen today, but it's still, I would say, a distal left main. I think this is really the perfect case for stenting because we have seen very complex left main today, and I think probably some of them could be referred to surgery, I think. But this probably is the good case, at least discussed with surgeons, I would say. But this is really the case, I think, when as as interventionalists, we can really get a good result as far as we do a correct job, of course, because we need to know the size, we need to have a good apposition at the end and so on. So it's very important. If you treat the patient with stent, you must be sure about your sizes and your apposition, especially for a left main. So it's a distal left main, Medina 100. So I think the best way to go for provisional stenting strategy. And here the plan was to put just a stent Nagomi from the left main to the proximal LED. And of course, here we will use an angio and OCT guidance. I say of course, because not all cath labs will do like this, but I think left main is really the lesion when you need to do that. I think it's not now in the guidelines, but I think it's really probably the lesion that really needs imaging because of the high risk of malapposition if you have a missizing. So the patient was preloaded with clopidogrel, and I just show you the, so first we did a light predilatation to be sure that the OCT catheter will cross easily. And this is the OCT images. And we see that actually it was a large proximal LED with I would say mean diameter around 4 millimeter. And the left main, it was difficult as always with the OCT to have really the true diameter, but we could estimate that the media to media was close to 5.3, 5.5 millimeter. And so in this case, and the length to cover, because there was already a stent in the proximal LED, the length to cover from the ostium of the left main to the old stent was around 14 millimeter. And so if you look at the overexpansion capacity of the Nagomi stent, we see that from 3.5 millimeter stent, you can upgrade the size up to 6.25 millimeter. This is confirmed by François Derimet, who has confirmed that in bench test. And so this is actually the case. So it was a 4 millimeter stent that we implanted from the ostium as proximal as we could to the proximal LED. So see, this is the result after the implantation of the stent, and then of course a pot. And it's not always easy to have all the sizes of balloon available in your cath lab. So here we had a 5 millimeter semi-compliant balloon. Probably it's better to have very large balloon available in your lab when you do a case like this, but we thought that in this case, a 5 millimeter semi-compliant balloon was enough to do the job. At 16 atmospheres, so we can expect that the size went probably close to 5.5, something like that. This is the rewiring of the circ, probably through a distal strut, but we cannot assess it, although I know that there's the October trial that was really looking at this, published now in New England. And this is the first inflation in the side branch, and then a kissing balloon. So we see that I'm not an extremist. Sometimes I do kissing balloon inflation, especially when the angle is very acute, because I don't want to have a shift, especially if the side branch is extremely large, like here. And the final pot. And at the end, we had that OCT control showing a few malapposition just at the distal part of the stent that we corrected afterwards. And we see very large opening at the level of the proximal LED and also at the level of the left main with very large minimal lumen area. And if we look at the ostium of the LED, it was good actually. We had an opening minimal surface area of 9.6 millimeters square, which actually fulfills the criteria that was previously published when using IVUS, and also the one from Nicolas Amabil with a lemon, which was published in Your Intervention, where we reach actually 80% of the reference lumen area. So we're quite happy with the result, and we see also very large opening of the struts towards the circ. And for the sake of time, and because it was also a busy day, we didn't do the OCT towards the circumflex. And due to the small malapposition and the proximal LED, we completed the result by another post-dilatation, and this is the final angiographic result, which I think it's acceptable. So the fourth case, if we have time, so it's a 59-year-old male, several risk factors, class 2 angina.
Just a second, Adel. Yeah. So we'll just look at the fourth case and ask any questions rather than doing the 5 minutes at the end summary. But
okay.
Should we just, so we'll give you a moment to do the fourth case quickly. Are there any questions in the interim?
Yes, case number 2.
Yeah.
The ESC is very clear about the guidelines.
Yes.
For short DAPT in HBR patients with ACS. It is 6 months. And for elective patients, is 1 to 3 months. So is it your normal practice to give short DAPT in ACS patients for 1 month or 3 months rather than 6 months?
So if you look at my slide, the ESC guidelines try to make a balance between the bleeding risk and the ischemic risk. It was an acute coronary syndrome, and we thought here that the bleeding risk was outweighing actually the ischemic risk. And you see on my slide that when it's like that, when the balance is more towards the bleeding risk, they propose 6 months of single antiplatelet therapy in combination with OAC and only 1 week of triple antithrombotic therapy. I can show the slide again if you want, but this is what they propose. If the ischemic risk outweighs, it's exactly what you said, actually. So we have to make a balance. Here, the patient was really a high bleeding risk patient, and also we have evidence from the master DAB trial that actually it works. Because in the master DAB trial, there was only 1 month of DAPT, and after that, the patient was put on single antiplatelet therapy. And actually, there was less bleeding and no more ischemic risk.
The second question, quick.
Yes? Yeah, please.
Ultimaster Nagomi, has it got FDA approval for short DAPT?
No. But yeah.
The platform and the drug and all of that is the same. I think that, I mean, the antiplatelet therapy question is really interesting still, isn't it? And however many studies we've done, I don't know, how many people give triple therapy for more than a month? How many people stop triple therapy after a month usually, or less? Yeah, which is not, again, not necessarily what the guidelines say. And how many people are happy with a DOAC alone after a year in complex stenting?
Yeah, me too.
Yeah, so again, the guidelines say it, but I think there are still a lot of us who are not confident that a DOAC alone, when you've done crush, culotte, left main, whatever, is necessarily good enough. So whatever the guidelines say and however many studies we have, we're still not quite there, are we, with the antiplatelets?
Another way is beyond this meeting is to close the appendage. Then you get rid of at least the antiplatelet therapy.
So should we skip through the last case in the last couple of minutes?
I still time to do the...
Yeah,
okay,
absolutely.
right, so very quickly. So 50 ejection fraction is okay. So the patient has a known significant proximal to mid-LAD lesion which was assessed by physiology with a positive FFR, low bleeding risk, normal renal function. So this is the case which was done by my colleague and friend. And you see that here it's very difficult actually, with a lot of overlap, and there is actually a proximal LAD lesion. And there is several difficult things to consider here. First, the left main looks very big, and then you have like a very large proximal part of the LAD just before the bifurcation. And so I think this is a typical case when you really need intravascular imaging because there is a high risk of missizing. I think it's a true bifurcation. I'm not sure about the side branch. It was very difficult to see where was the side branch. So we went for a provisional because we thought that it will be good. Angio and IVUS guidance in this case. So I show here the measurement. So a very large left main actually, which really preclude us to go from the left main to the proximal, to the beyond the diagonal, because that would be too much difference between the distal and the proximal part. You see the proximal LAD is relatively large actually, close to 4.7 of maximal diameter. And the distal one is around, I would say, the mean diameter should be around 3.2, 3.3, something like that. And here, of course, we can use the overexpansion capacity of the mid part. As you can see here, if you use a 3 mm stent, we can go up to 4.5. So usually we should, normally you should have a good apposition in the proximal part. That's what we did actually. So by really trying to find a good projection, so we first we predilated the proximal LAD when we put a Nagomi 3 mm, 44 mm length. And then really it was difficult to find the right plane to place it just at the ostium of the LAD, which actually I think was successful here. And then a first relatively shy pot with a 4 mm semi-compliant balloon, despite the fact that we saw that the vessel is bigger. And then there was a very big difficulty to go back with the wire in the diagonal. And so really there was a stent enhancement showing that the proximal part was not adequately predilated with a pot. I mean, not adequately opposed with a correct pot. So we went for a more aggressive pot with a 4.5 mm non-compliant balloon. And then we could cross the diagonal and do like a classical pot side pot technique. And this is the final result. And very quickly, this was the final result. So relatively good minimal surface area at the level of the proximal LAD, and also a very good apposition proximal without protruding into the left main. And all these cases were done through radial approach because now we have, it's a Terumo symposium. It's not about vascular access, but I think there's no need to go for femoral for all these cases. Most of the cases were done with only 6 French glycid sheet slender, sometimes with a distal radial access. And even if, I mean, you still have also the 7 French slender sheet that, so you can tailor your sheet size according to your indication. Left main, usually I do 7 French slender, but everything else I use 6 French slender. So I think this is also something that we need to consider if you want to decrease the bleeding risk in those patients to go through radial. Always good to go radial instead of femoral. Thank you very much.
Thank you. And they were great cases, Adel, and I think they, we've got the confidence with the modern stents that we can do all of these sorts of things, but the registry is going to be really interesting, isn't it, to have a large number of complex patients in a registry and see if the outcomes are as good as we think we are. Yves?
Only a few words. Adel, finally you found the good projection.
Yeah.
So maybe you can spend a bit of more time to have the good projection from the beginning.
Sure. There was a lot of overlap in this case. It was a nightmare. And I see all these cases I've shown are included in the registry. Yeah? So it's going to be interesting to see the outcome of those patients. And to really, you have a theoretical aspect of the new platform and so on. And now it's really assessed clinically in a large registry. So it will be interesting.
Be interesting to see how much imaging is used as well, because we all say that we always image in complex patients.
No, it's real life. It's real life. I can tell you the second case I've shown, it was without imaging. So,
which is an introduction into the next session.